Scleral Lenses, a review of recent literature with Dr. Mindy Toabe, Dr. Muriel Schornack. I'm going to read their bios now. So Dr. Toabe is a hospital-based optometrist in a multidisciplinary setting in primary care, pediatrics, and medical contact lenses, practicing at Metro Health Center within the Department of Surgery, Division of Ophthalmology in Cleveland, Ohio. She's a senior instructor at Case Western Reserve University School of Medicine, while also working with ophthalmology residents at the Cleveland Clinic Cole Eye Institute. Additionally, she is an adjunct faculty at The Ohio State University College of Optometry. Dr. Toabe is currently the president of the Scleral Lens Education Society and an invited member of the International Society of Contact Lenses. Dr. Toabe is also on the advisory board for the Gas Permeable Lens Institute. She has lectured both nationally and internationally about specialty contact lenses, including scleral lenses. Her main areas of clinical and research interest are primary care, ocular disease, dry eye management, specialty medically necessary contact lenses, dry eye, and contact lenses. Dr. Muriel Schornack is a consultant at the Mayo Clinic and holds the rank of assistant professor in the Mayo Clinic College of Medicine. She's also responsible for the development of Mayo Clinic's scleral lens program in 2006. Since the inception of Mayo's Scleral Lens Clinic, Dr. Schornack has lectured, presented, and published regularly on the topic of scleral lenses. Dr. Schornack is a founding member of the Scleral Lens Education Society and currently serves on the advisory board for the organization. She was also a founding member of the SCOPE, or Scleral Lenses and Ocular Ophthalmic Practice Evaluation research team, and remains active in the group's leadership. And with that, I will turn it over to you two.
Thank you very much, Drew, and thank you everyone for joining us. I just want to remind everyone that this literature being reviewed tonight is about scleral lenses. Here is a quick review of what we're going to talk about during this webinar. Next. And again, we're talking about scleral lenses. Next. So 2017 thus far has been a blockbuster year for scleral lens research. We have a total of 20 peer-reviewed published works just in this year alone. Next. There were 6 categories of published literature about scleral lenses up until 2016, with the largest category being case reports and case series. There were more case series than single case reports in 2016. In past years, there were more single case reports. The next largest topic was observational studies, followed by prospective studies. Next. In 2017, the largest category shifted from case series to prospective observational studies. This shift in published literature indicates that the past case series case reports published have demonstrated that scleral lenses are useful, provide better vision, protect the cornea, and can improve quality of life for our patients. The increase in prospective observational studies will allow us to start to understand changes occurring to the ocular surface with scleral lens wear. Next. Here's a listing of case reports and case series demonstrating the shift of increasing case series and decreasing single case reports over the last year. It appears that single case reports last year were in the form of either new or more complex conditions treated with scleral lenses. In 2017, there were a total of 3 case series and 1 case report, and those are indicated in red. Next. The single case report in 2017 discussed a piggyback design for keratoconus using a small diameter corneal scleral lens. No ocular or corneal problems were observed over a 1-year period. Next. In 2016, Barnett found that the most common indications for penetrating keratoplasty was keratoconus, with a total of 56% in the study. 35% in this study discontinued the fitting process due to application and removal. Patients who continued wearing scleral lenses were more likely to report good subjective vision compared with patients who abandoned scleral lens wear, although change in objective visual acuity did not differ significantly. 5 patients developed graft rejection. 3 patients out of those 5 were able to resume scleral lens wear, and there were no cases of infectious keratitis. In 2017, Rocha retrospectively reviewed 21 patients that were fit in scleral lenses, studying visual rehabilitation outcomes and complications associated with scleral lens wear and penetrating keratoplasty. 6 eyes out of 27 eyes developed complications, including 1 patient with bilateral corneal edema. Contact lens discomfort and intolerance, with 1 case of microbial keratitis, was found in this study. The microbial keratitis was treated without complications. Next. Here is a case series discussing a new complication of scleral lens wear. 14 healthy patients with a normal corneal curvature were fit with a 14.6 small diameter lens. Epithelial bullae, molding, and epithelial erosions occurred as an unintended complication of contact lens bearing on the cornea. Next. Rathi found over a 2-year period 5 patients with both Stevens-Johnson syndrome and keratoconus. 1 patient developed deep vessels in the cornea. This patient was treated by decreasing wearing time and using a higher decay material lens, resulting in regression of the blood vessels. This is the first published report of neovascularization due to scleral lens wear. 1 patient developed conjunctival inflammation and discontinued scleral lens wear. The etiology of keratoconus in patients with Stevens-Johnson syndrome is unknown, although eye rubbing may be a factor, since eye rubbing may increase the eye temperature, leading to increased inflammatory activity. Said and group also studied Stevens-Johnson syndrome with corneal ectasia and proposed that inflammation and ulceration of the eye can lead to complications from blink-related microtrauma. In addition, abnormal eyelid to corneal interactions may contribute to corneal ectasia due to altered tear film stability from MMP expression. In both studies, the diagnosis of Stevens-Johnson syndrome occurred before the patient was diagnosed with corneal ectasia or keratoconus. Next. In 2016, the PROSE lens was studied for exposure keratopathy due to lag ophthalmos, ectropion, and lid retraction. 18 out of 29 patients with 62% study completed the fitting process. 11 patients were excluded. 4 patients were excluded due to glaucoma tube shunts, which created irregular conjunctival surfaces hindering the fit. And 7 patients did not complete their fitting process. In terms of wearing the device, 10 reported most of the time and 5 patients reported half the time. The average number of visits was 5 visits with a range of 2 to 8 visits. Corneal staining and dry eye decreased, concluding that scleral lenses can serve as an alternative to lid surgery. In 2017, Zaki studied exposure keratitis and scleral lenses for use secondary to facial palsy and concluded that scleral lenses should be considered for all patients with facial palsy. Zaki's publication is especially important because it was published in a non-ophthalmology journal, indicating that scleral lens use is becoming acceptable as a treatment option within the medical community. Next. There were 2 retrospective reviews in 2017, both related to oculoplastic surgery and severe corneal surface disease. The first, by Schofield, reviewed 9 cases whereby all had multiple lid surgical procedures and yet continued to suffer from exposure keratopathy, eye pain, and decreased vision. In one group, the patients with facial nerve palsy, lag ophthalmos, and decreased tear production, this group, using the PROSE device, they were able to stabilize the ocular surface without worsening the lid position. In another group, the PROS device raised the upper lid so that lid surgery was delayed. In the third group, the PROS device stabilized the eye to prepare the eye for lid surgery. This study is different than the exposure keratopathy case series just mentioned because this paper discusses ptosis management in addition to exposure keratopathy. The second study from the University of Iowa looked at the relationship between oculoplastic procedures and scleral lenses. This study found that oculoplastic procedures can aid in scleral lens fitting by improving the scleral lens fit. In addition, this study confirms that when surgical intervention fails in halting progressive keratopathy, scleral lenses do help to protect the cornea and provide better vision. Next. Now we'll explore prospective observational studies looking at what the effects are on the ocular surface as well as other topics related to scleral lenses. Next. Does dry eye in patients with keratoconus change with scleral lens wear in terms of tear film biomarkers? In this study from Madrid, Spain, patients were divided into two groups, patients with keratoconus and patients with interstromal corneal ring segments. Results showed that patients with keratoconus had a decrease in signs and symptoms of dry eye, but MMP9 concentration rose significantly. This group speculated that the rise in MMP9 may be due to tear film stagnation and the use of saline for filling the lenses. Next. What is the success rate and efficacy of the ICD 16.5 diameter lens? Research from France found that 15 out of 23 patients completed the fitting process. Discontinuation of scleral lens wear was due to difficulty with handling, lack of motivation, or unsatisfactory visual acuity secondary to residual internal astigmatism. 50% wore lenses 10 or more hours per day. In terms of handling the lens, 60% had no difficulty after 1 month, whereas 20% had continued difficulty and 20% required a caregiver. Those two were children. There was one complication in this study, and that was corneal graft swelling, and one adverse event, conjunctival hyperemia, which was resolved by fitting a higher sagittal height lens. 2 patients developed a problem, which was deposits between the lens and the ocular surface. Next. How does corneal curvature and higher order aberrations change with scleral lenses? Vincent and group from Brisbane, Australia found significant corneal flattening with an increase in against the rule astigmatism, primarily in the superior mid-peripheral cornea, or outside the central 4 millimeters. Vincent proposes that superior flattening may result from lens removal rather than lens wear due to negative pressure being released during removal along the vertical meridian. Changes were found in higher order aberrations, but the magnitude of these changes were small and would not result in changes in vision during lens wear. However, spectacle blur may occur with normal corneas as up to half a diopter of cylinder was observed in some participants. Next. Another study by Vincent and group looked at power profile and optical quality of scleral lenses with different powers as a function of aperture. 5 powers were measured per design using 3 and 6 millimeter apertures. Results from this study and previous studies show that differences in optical power depend on lens design, which may affect visual performance. This could be due to the tear reservoir, which can influence ocular aberrations. In this study, contrast and spatial frequency was similar within the same design at 3 millimeter apertures. Visibility decreased with a 6 millimeter aperture. In summary, The power fluctuations were insignificant along the optical zone of each lens, and optical quality was independent of lens power within each aperture. Further studies are needed to assess different degrees of decentration on visual performance, as this study focused on ideal centration. Next. Is there a temperature change with keratoconus under scleral lenses? Does the temperature change correlate with tear production and stability? This study from Madrid, Spain recruited 26 patients with keratoconus. 8 points were studied, 4 on the cornea, 2 on the limbus, and 2 on the conjunctiva. Keep in mind, some authors consider the ocular surface temperature a tear film stability and inflammation indirect marker. Results of this study show that scleral lens wear does not modify the ocular surface temperature in patients with keratoconus, despite the tear film stagnation under the lens. These results suggest that not enough inflammation occurs in the ocular surface during scleral lens wear to increase the ocular surface temperature. I also want to mention that a couple of years ago, and recently there have been some studies that show that intraocular pressure also does not change under scleral lens wear. Next. This prospective study from Montreal, Canada shows that an 18-millimeter lens with 400 microns of apical clearance decreases oxygen tension by 30% due to the cornea compared to a lens fit with 200 microns after 5 minutes of wear. Next. Now we'll explore prospective observational studies in terms of how a practitioner evaluates a scleral lens, patient experiences, and specific fitting characteristics of lenses. Next. How accurate is a new clinician in their assessment of central corneal clearance? Dan Fuller and his group from the Southern College of Optometry in Memphis, Tennessee had 54 fourth-year optometry students examine the central corneal clearance on normal subjects and compared their results with anterior segment OCT. This study found that these students overestimated the amount of central corneal clearance with less accuracy as the amount of central corneal clearance decreased. Next. Jan Bergmanson from the University of Houston asked patients with keratoconus to complete a survey and dry eye questionnaire. This group assessed perceived comfort and experiences of adapted scleral lens wearers with a history of keratoconus and a history of wearing other lens designs. Compared to other lens modalities, these patients preferred the comfort and vision of scleral lenses and experienced less dryness. The average wearing time with their lenses was 14 hours with a range of 7 to 18 hours, whereas with their other lenses, the average was 10 hours. More than half of these patients experienced midday fogging, which seems to still be a problem with scleral lens wear. Next. This study examines patient experience and explores the significance of diagnosis and age. The objective of this study was to compare the ease of adoption of a prose lens by patients either by age, less than 60 years old or greater than 60 years old, and by diagnosis, either corneal irregularity or ocular surface disease. Based on this study, patients can expect to go through about 5 devices per eye and 12 visits during the fitting process. Understand that the fitting process may be influenced by the proclivities of the prescribing practitioner and the policies and ease of accessibility of the site. There was a rapid increase in wear time over a 2-week period, with patients reaching over 8 hours. Age and diagnosis was not a limiting factor for increasing wearing time or for daily application and removal of a device. Patients reported the lowest difficulty rating for application and removal by week 6 and spent less than 5 minutes for each task by week 5. Next. This article from Italy by Dottie Fidel defined mini and large scleral lenses not based on diameter of scleral lenses, but rather based on a formula that combines horizontal visual iris diameter, limbal width, and landing zone. Based on the formula, a mini scleral lens will have a landing zone less than 1.5 millimeters, while a large scleral lens will have a landing zone greater than 1.5 millimeters. The benefits of mini versus large scleral lenses is discussed in this review article. In summary, mini scleral lenses can be made thinner with less central and limbal clearance and have minimal interaction with scleral irregularities and toricity. By contrast, large scleral lenses can provide increased vault, aid with protecting a larger area of the eye in cases of advanced ocular surface disease, may decrease lid interaction, which will allow for better comfort and can solve problems with conjunctival irregularity, compression, and staining. In summary, there are many factors that come into play with total diameter. This article provides a good starting point for initial lens choice. Next. Eason from Brazil applied 3 different lenses with 3 different sagittal depths to 11 patients with keratoconus. Central corneal clearance was measured with OCT and pentacam in the morning and immediately upon removal. It was found that settling was influenced by both the apical clearance and the diameter of the lens. Vision and comfort were not influenced by apical clearance. And steep faults above 300 microns of clearance did not cause significant corneal edema compared with low vaulting lenses. Keep in mind that the effect of long-term lens wear in eyes with unhealthy endothelium is unknown. This study agrees that current clinical practice aiming to use the highest decay material and minimizing the apical clearance and scleral lens thickness is still the best practice for corneal physiology. Next. Scleral lenses may play a role in low vision treatment. Scleral lenses do provide good stability for an eyepiece. However, the issue of corneal edema creates a challenge in designing scleral lenses as telescopes. Age changes in conjunctival morphology in older patients, especially conjunctival thickness, which decreases with age and could lead to increased compression and negative pressure affecting corneal oxygenation and lens removal. Next. There were 3 published reviews pertaining to ocular disease and 1 review of systemic disease recently. Perry Rosenthal published an overview of disorders of the corneal pain system in the context of neuropathic pain as it relates to dry eye disease. These conditions are characterized by unexplained chronic pain. Some conditions discussed include neuropathic pain following corneal nerve injury, oculofacial pain, fibromyalgia, and other disorders related to refractory dry eye. Scleral lenses and glaucoma surgical considerations were studied using the PROS design. It was found that prior planning for glaucoma drainage implants using a pars plana tube placement with a posteriorly placed patch graft instead of an anterior chamber tube positioning with more anterior graft enabled adequate scleral lens wear. The systemic disease that received attention was chronic graft versus host disease, with an emphasis on SLK-like inflammation and secondary limbal stem cell dysfunction. SLK-like inflammation is an under-recognized condition in patients with severe dry eyes secondary to ocular chronic graft versus host disease. Untreated SLK can lead to permanent limbal stem cell deficiency over time. Early recognition and management of SLK and ocular chronic graft versus host disease can improve vision, reverse signs, and may prevent these long-term consequences. Next.
Well, now I'm going to take over. This is Muriel Schornack. And again, thank you very much for joining us this evening. We're going to change gears just a little bit and talk about some papers that have been published recently that are not directly related to scleral lens prescription and management, but certainly have an effect. But I thought it might be useful to just stop for a moment and figure out, what do we think we know? What do we really know? What do we need to know? And how can we find out? So we think we've got a pretty good idea on indications for scleral lens wear. We think we've got a pretty good idea on the solutions needed to manage lenses. We're starting to think that we have a good idea on optimal fitting characteristics. And so we've certainly made a lot of progress during the past couple of years. But then the question becomes, what do we really know? A lot of what we've done so far is very preliminary. The sample sizes are small. A lot of work is based in theory rather than clinical practice. So I think there is some room for clinical studies to assess outcomes of scleral lens wear. Now, what do we need to know? I would suggest that we really need to get a handle on how these lenses may be affecting the ocular surface in ways that corneal lenses do not. These are large diameter rigid lenses, and so like a soft lens, they extend beyond the limbus onto the sclera. But unlike a soft lens, they are rigid, and so maybe having some effects on conjunctival tissue and underlying tissue that we're not fully aware of. They are made out of the same material as rigid gas permeable corneal lenses, but the fitting characteristics are so very different that we can't assume the same risk profile. The last thing that we need is a series of complications with these lenses that could very quickly dampen enthusiasm for them. This would be unfortunate because they do provide such great benefit for many of our patients. So how can we find out what we need to know? Well, at this stage in the game, we're kind of in the garden prep arena. Now, I know this is the wrong time of year to be talking about gardening unless you live in the southern hemisphere, which I do not. We're expecting snow here in Minnesota by the end of the week. But in the spring, as we're gardening, we need to do a ton of soil preparation and weeding and preening before we think about putting those plants in the ground. So I think there's a lot of background questions that need to be answered before we can really answer those questions that we want to know. So one of the things that one of my mentors impressed upon me years ago is that you have to ask 3 whys before you can really get down to the meat of a research question that you may want to explore. So you've got a great question, and then you ask yourself, well, why do I want to know this, or why does this happen? And you ask that question 3 times, and by the time you're at the 3rd why, that's when you can start to really answer one of the questions that we're looking at. We need to standardize measurement techniques, and we need to develop some normative data for not only scleral lens wear, but anterior surface parameters. Starting with the sclera. We call these scleral lenses because they do not rest on the cornea. They instead rest upon the sclera. And so it would be interesting and useful to know what the scleral shape is. And this study took a look at an estimate of axial curvature of the anterior sclera by taking a look at axial length and angle kappa. Now, it would make sense that the longer or larger an eyeball is, the longer the radius of curvature would be. And this study did in fact find that it was the axial radius was, or axial length, anterior chamber depth, and white-to-white measurements were in fact useful parameters for estimating the anterior radius of curvature of the sclera. We also may want to know how stiff that sclera is. The sclera is certainly more stiff than the conjunctiva tissue that overlies it, but we may want to know how we could potentially be altering scleral shape by using scleral lenses, particularly if we are considering the possibility that scleral lenses may cause some remodeling or disfiguring of Schlemm's canal and thus affect intraocular pressure. So in this study, 24 post-mortem eyes were studied and discovered that the scleral stiffness seemed to increase with age as well as increasing with diabetes. We also may want to know how thick a sclera is. This study took a look at scleral thickness using anterior segment optical coherent tomography. Now, there is no automated method of measuring scleral thickness just yet, unlike measuring corneal thickness, which we can do with either a pachymeter or with the pentacam or anterior segment OCT. So this is all done manually. In this particular study, scleral thickness was measured using anterior segment OCT in 74 young individuals. They measured in 1 millimeter increments from the scleral spur out 6 millimeters in 8 different meridians. And then they assessed intra and inter-observer variability since this was a manual measurement. The median scleral thickness was about 725 microns. And of interest, the superior nasal sclera was the thinnest and the inferior was the thickest. So it appears that the sclera is not of equal thickness all the way around, which is an interesting finding, given that we know that muscle insertion and scleral curvature is not equal all the way around either. Here's another study measuring the metrics of a normal anterior sclera using anterior segment optical coherence tomography. And again, this study took a look at a wider range of ages, that is 18 to 92 years, and still discovered that the supranasal quadrant was the thinnest area, followed by the supratemporal quadrant, followed by the infratemporal, and then the thickest was in the infranasal quadrant. And again, this study verified that scleral thickness does increase with age. When you think about it, we're not truly landing on the sclera. We are actually landing on the conjunctival tissue that overlies the sclera. So in order to determine what scleral lenses may be doing to conjunctival tissue, we would want to define the baseline conjunctival thickness. And in fact, Reed and his colleagues have published several articles on anterior segment morphology, including scleral and conjunctival tissue, took a look at a number of young healthy patients and measured the thickness of the conjunctiva and the sclera in these young adults, discovered that younger subjects tended to have somewhat thicker conjunctiva and thinner sclera, which I thought was kind of interesting. And just when you think you've got this all down, you can read the next paper, which tells you that there is some variability in thickness of the conjunctiva from one part of the day to another. Now, I found this interesting because if you're talking about a smaller scleral lens, you're going to land on conjunctival tissue that is closer to the limbus, which means you might get a little bit more settling there since that conjunctival tissue is a little bit thicker. If you are working with a young patient, you might discover that there is a little bit more settling than in an older patient since conjunctival tissue is somewhat thicker in younger patients and therefore potentially more compressible. If you are measuring the fit of a scleral lens that has been applied immediately after waking, you might wish to do another evaluation later in the day, as conjunctival tissue does tend to thin during the course of the day. We can take a look at corneal thickness as compared to scleral thickness in patients with keratoconus in this study. As we all suspected, the sclera in keratoconus patients appears to be relatively normal, even in patients with keratoconus compared to control subjects, even though the corneal thickness is decreased. So if we're talking about a scleral lens that is supposed to vault cornea and limbus and land on the conjunctival tissue beyond the limbus, we may want to know where the limbus is. This study took a look at results of the eye surface profiler and reported on data collected from 4 young healthy patients. There were a couple of interesting findings here. First of all, image intensity transition does not correspond to topographic change. So if you're looking at an image and you're saying, where that optical density increases, that's where the limbus occurs, that's not an area that corresponds with a change in curvature, a change in angle on topography. So if one considers this further, you could realize that taking a look at horizontal visible iris diameter may not accurately identify the location of the limbus. So there's obviously still some work to be done in that area. And that is precisely the conclusion that was drawn by Jan Bergmanson from University of Houston. He did a literature review and discovered that the measurements for the limbus that we are currently quoting were all based upon papers that were published a number of years ago and may or may not be based upon the actual observation of the limbus. So there's certainly some work to be done in this area. He discovered that the actual limbus may be broader than we had given it credit for, and suggests based on that on an average cornea, a scleral lens would need to be 16 millimeters in diameter or larger in order to fit according to scleral lens fitting guidelines, that is, completely vaulting cornea and limbus. This study took a look at a comparison of corneal diameter and anterior chamber depth. Now, one could think that a larger diameter would result in a larger anterior chamber depth, but this does depend upon the curvature of the cornea as well, of course. Took a look at this measurement as gathered using 4 different devices. And this is important because not all of us have the same devices in our office. And so we need to be able to assess whether or not the measurement that we're getting with our particular instrument could be comparable to an instrument obtained, or I'm sorry, to a measurement obtained on another device. And in fact, this study found that all of these devices, the IOL Master, LensStar, Pentacam, and Visante OCT, provided reliable and accurate measurements of these parameters. This study took a look at the intrasubject repeatability of corneal power, thickness, and wavefront using a new version of the Scheimpflug imaging system. The Pentacam is probably the most commonly used Scheimpflug-Placido imaging system that we have here in the United States. But this particular study took a look at the Galileo G4 system, took a look at 25 eyes of 25 subjects, and 3 measurements were taken from each eye. This study found excellent repeatability with this instrument for corneal thickness, and also found no significant difference between corneal power assessment when measuring with this system compared to earlier systems. This study looked at differences in results when different operators obtained the images and found that there was excellent agreement both within the same observer and within different observers for collecting this information on these instruments. So what we really want to know, if we've determined that the instruments are all collecting data appropriately, is whether or not these instruments can be used in selecting that first lens in scleral lens fitting. And in this study, we found that in fact, there was a positive correlation between lens sagittal depth and anterior chamber depth in patients with keratoconus who were fit with scleral lenses. Now, of interest, there were no statistically significant correlations in patients with dry eyes. And that actually corresponds with the study that was published earlier that found no correlation between anterior segment parameters and scleral lens base curve in patients with dry eyes. So why you would see a correlation in keratoconus but not in dry eye disease is one of those mysteries that we still need to investigate further. This study was published by Esther Simone Visser and her group in the Netherlands and provides a very nice protocol or paradigm for deciding which lens to fit given a particular condition or severity of a condition. So the blue boxes on the left are lenses that would be fit for management of ocular surface disease, and the green bar on the right overlies conditions of corneal irregularity and the severity of that irregularity. And if you follow the arrows down, it gives you a very nice idea of the lens that may fit this person's needs the best. One of the interesting possibilities with scleral lens wear is the fact, it arises from the fact that scleral lenses maintain the fluid reservoir behind the lens. So if you did have an eye that needed prolonged contact with some therapeutic agent, it may not be a bad idea to put that agent behind a scleral lens. But of course, we would want to make sure that the epithelium was not damaged in that case. And in this study, the researchers took a look at the state of the cornea after the eye had been doused in a scleral lens with ofloxacin during 4 hours of lens wear. The study took a look at the concentration of the medication in the cornea, aqueous, and vitreous. Unfortunately, there was some evidence of superficial keratitis in the treated eyes, not in the control eyes. So it appears that using an antibiotic agent and keeping it in prolonged contact with the cornea may not be the healthiest thing for the corneal epithelium, even though we could potentially achieve wonderful concentrations of that medication within ocular tissues. So what are some emerging areas of studies? Well, we all know that scleral lenses settle on the front surface of the eye, but we are unsure of exact characteristics of that settling. Dr. Sherry and I published a study earlier this year in Eye and Contact Lens that assessed quadrant-specific settling, and we discovered that lenses appear to settle most in the superior and supranasal quadrants, which sort of makes sense given the fact that that's where the lid is in competition with the scleral lens to reach the front surface of the eye. We noticed less settling in the inferior quadrant. This could mean that the lens is decentering. It could mean that there's actually more settling in the superior quadrant compared to the inferior quadrant, but this is certainly an area of investigation that will require further definition over time. Also in 2017, a study was published that took a look at settling characteristics using different filling solutions. This study discovered that there was no difference in settling characteristics whether one used saline or whether one used a more viscous agent to fill the bowl of the lens prior to lens application. We also are beginning to see studies that examine the effects of scleral lens wear on conjunctival tissue. Laporta-Weber published an article on impression cytology in scleral lens wearers in 2017 and discovered that scleral lenses do in fact appear to change goblet cell density. And then we need to get some idea of the characteristics of that post-lens fluid reservoir. We need to determine what's in it, what may be causing trouble with that lens reservoir, and Placido et al. Published an article in Clinical and Experimental Optometry earlier this year for precisely that reason. The SCOPE study was a study that some of you may have participated in. If you did, you would have answered or responded to a questionnaire that was sent out in early 2015. The SCOPE study group was attempting to get a bit of a snapshot as to scleral lens prescription and practices as of that time period. And three of those studies have now been published. We were not sure exactly what to expect, but we received 989 responses, which means that there are at least 989 individuals who have fit one or more scleral lenses. Of those individuals, 723 had fit 5 or more lenses during the course of their careers. And when we asked those 723 providers to estimate the number of scleral lens patients that they had fit and added all of those patients together, we came up with 84,375 patients. Conversations with representatives from industry prior to the initiation of that study estimated that there were approximately 40,000 patients worldwide who were wearing scleral lenses. So to find evidence that there were at least twice that number was surprising, to say the very least. We discovered, as we expected, that the most common indication for scleral lens wear was in fact corneal irregularity, and collected quite a bit of data on prescription and management practices. We're still working through some of that data, so stay tuned. There may be more work coming out in the future. So what is it that we still need to learn about scleral lenses? I think given the fact that we're just beginning to understand conjunctival tissue, it would be helpful to understand the impact of scleral lenses on that tissue. We're not exactly sure how that may affect function. Conjunctiva is somewhat forgotten tissue. We just assume that it's going to be there and it's going to behave well, but it is the repository of quite a bit of the immune system in the eye, and so we want to make sure that we're not damaging it in any way. I think we should evaluate scleral lens induced changes on conjunctival thickness and structure, including things like goblet cell density, because if we're treating one disease and causing other disease due to alterations in goblet cell structure or function, we may want to be aware of that. We certainly want to find evidence of any sign that scleral lenses can cause cornea changes. Now, there have been several studies that have indicated that scleral lens wear can cause at least short-term changes in corneal curvature. We want to know whether that's permanent or if it bounces back, and if so, what is the time period that's necessary in order to allow that cornea to recover. We should take a look at corneal thickness, but not only thickness, we should also take a look at corneal volume. Thickness is measured in a particular point on the cornea, but if you happen to measure a slightly different point, you could get a little bit of a different thickness. Volume may be a better overall assessment of corneal thickness and corneal hydration. We also want to take a look at corneal nerve structure and function. Wearing a scleral lens decreases the feedback mechanism for the cornea and may alter nerve structure or function due to that. And then, as Mindy indicated earlier, there have been a couple of studies taking a look at scleral lenses and intraocular pressure. Those studies are small and are looking mostly at young and healthy individuals. If we are fitting these lenses on older individuals who have more pathology, we may want to do further study just to make sure that we're not doing any damage there. Now, what are some of the other things that we need to pay attention to? Well, we need to figure out how worried we should be about conjunctival prolapse. Of interest, this is a picture of one of my patients. And when I removed that scleral lens, the conjunctiva stayed there. I got all excited about it, altered the fit, never was able to eliminate that conjunctival prolapse. She was unable to wear her lens for approximately a week while she was hospitalized, came in to see me shortly thereafter, and conjunctival tissue, which I had thought was adherent to the cornea, had now released fully. So perhaps I didn't need to be as worried about it as I was, but this is certainly something that we need to investigate further. It may be that we should not worry about this at all, but I'd like to know that before I come to that conclusion. Fluid reservoir debris is certainly an irksome problem for many of our patients, and we are starting to see some very good work that takes a look at what could be the components of that fluid reservoir debris. There is still much work to be done, though, to discover any risk factors or fitting characteristics or patient characteristics that may make it more likely that a patient will experience this particular problem. We need to get some ideas to what the ideal fit may be. There's a lot of talk right now about fitting a small lens relatively close to the cornea, and while that may be appropriate in some cases, it may not be the most appropriate thing in all cases. I certainly agree that oxygen to corneal tissue is very important, but there's two ways to get that oxygen. One is direct diffusion through the lens and fluid reservoir. The other could be tear exchange under the lens. So if you're looking for tear exchange under the lens, you may not wish to fit small and relatively tight, because that small lens may in fact settle into the conjunctival tissue, which is a little spongier right around the cornea, more than a larger diameter lens would. So I think we need to look at some outcomes of scleral lenses fit using various parameters and come up with some ideal fitting characteristics based upon that evidence. So what are lens wearing and care schedules? We're starting to get a handle on this. Most of us now agree that we need to use non-preserved products in order to fill the bowl of the lens. With the advent of HydraPeg, we need to carefully consider what we're using to remove surface debris from the lenses. And then what do we want to do for wearing schedules? Do you want the patient to wear it as much as possible, or do you want to wear it just enough to get the therapeutic effect that you're looking for? Do we want to routinely recommend midday removal, or only recommend it if patients are having problems with the lenses? And then when should scleral lenses be used? I really do consider treatment of corneal irregularity and ocular surface disease in a rather stepped manner. If a patient is able to achieve adequate vision with spectacles with regards to corneal irregularity, there's really no need to move beyond that into a more complex sort of a fitting or contact lens fitting process, unless the patient wishes to do so. By the same token, I wouldn't put somebody in a scleral lens for ocular surface disease if they hadn't tried some less invasive, less burdensome care regimens first. And then finally, we need to know the complications of scleral lens wear. What is the risk of microbial keratitis associated with scleral lenses? And what are we doing to the conjunctiva when we put a scleral lens on the eye long term? Are there characteristics of patients that are particularly successful? Are there specific diagnoses or personality traits? This would help us as we try to determine the likelihood that a particular patient would be successful with scleral lens wear prior to initiation of a fitting process, which could be rather prolonged and which could be expensive for the patient if insurance does not cover the lenses or the visits during the fitting process. So in conclusion, there has been an explosion of growth in both quality and quantity of research regarding scleral lenses during the last several years. And we're starting to see the development of specific areas of study within the scleral lens research community. So we are still in the process of determining the variables that need to be controlled when doing such research. We don't, as of yet, have any multi-center studies, which would be very useful when we're talking about even case series from a particular center. It tends to be somewhat anecdotal. It whatever is being reported obviously worked for that center, but may not be generalizable to practice at large. And so if any of you are interested in performing scleral lens related research, there's plenty of room. And if you want some ideas, give me a call. I'd be more than happy to share them with you. This concludes the formal portion of our presentation this evening. If there are any questions, I think Andrew is going to moderate that.
Yeah, we've got a few questions here. First one in the article about kind of the mini scleral versus large scleral lenses. What would make you choose a mini scleral versus a larger diameter?
Okay. Hang on.
If I may answer while Mindy's looking for her study there, in my personal opinion, I tend to use larger lenses for patients with ocular surface disease. I want to protect as much of the front surface of the eye as I can, and so a larger diameter lens will allow me to do that. The other time I may consider a larger diameter lens is in cases of severe corneal ectasia, where I need to make a lens that's quite deep. I found that larger lenses can actually support that increased depth just a little bit better than some smaller diameter lenses. But this is my clinical experience and has not been researched in any sort of a systematic way. So this is my opinion only.
Hello?
Mindy, anything to add to that at all? Well, if not, I'll let her collect a few things. And I have one more question here in reference to the article about scleral lens settling. How would you handle settling in a clinical setting, since most of it occurs within 4 hours?
We would certainly want to make sure that we evaluate that lens after it's had a chance to settle on the eye. Now, I think most of the studies on settling have shown that lenses are not going to settle any more than 50%. So for instance, if you start out with 400 microns of central corneal clearance, you're not going to end up with anything less than 200 microns. Now, you may end up with 375, but if our goal is to keep that lens off the cornea, if you assume that it's going to settle by 50% and fit accordingly, you should still be in pretty good shape. Personally, I always wait about 20 minutes before I evaluate a lens on an eye. But I may go through 5 or 6 lenses in quick succession in order to get that extra vault that I know I'm going to need, and then let it settle over time. I hope that answered the question.
Yeah, that's perfect. Anything to add there, Mindy? I think we might have lost her. Well, I think that's all we have today. Thank you guys so much for that wonderful presentation. For all of the attendees, there will be a quiz going out tonight or tomorrow that you have to fill out and obtain a 70% on in order to qualify for COPE credit. We'll have about a 2-week window for you to answer those quiz questions and get them back in. All that information will be included in the email going out either later tonight or tomorrow. Thank you to, again, doctors, for a fantastic presentation. Again, if you missed any of the previous lectures, they are all up on sclerallens.org, the Scleral Lens Education Society's homepage. Thanks again. Everybody have a great night.
Thank you.